Have you ever wondered what happens when cancer patients reach the most critical, vulnerable stages of their treatment journey? Or how radiation therapy helps not just to treat, but to comfort? In today's video, we're diving deep into emergency situations in radiation therapy and the emotional role of art play in providing psychological support to patients in end-of-life care.
This video is not just for professionals. If you're a student, a caregiver, or just curious, stay with us till the end. And don't forget to hit subscribe so you never miss any insight from the radiotherapy world.
Comment your experience as an RTT or caregiver below. Let's begin with the palliative and emergency aspect. Palliative radiotherapy is not aimed at curing the disease, but at relieving symptoms. Indications for emergency radiotherapy. Spinal cord compression, SCC, primary emergency indication. Treatment should start within 24 hours of diagnosis. Other indications include SVCO, bone pain, hemorrhage from tumors, etc. Spinal cord compression, SCC. Medical emergency. Most common cause, metastatic tumor to vertebrae, lung, prostate, breast, thyroid, lymphoma, myeloma. SCC can result from benign causes, e.g. abscess, fracture. Cord ends at L1, compression below causes cauda equina syndrome. Clinical features. Early signs, radicular back pain, sensory disturbance, motor dysfunction, bladder, bowel issues. Common in thoracic region, cervical signs affect arms, lumbar signs mimic cauda equina. Treatment. Start high-dose steroids, e.g., dexamethasone 16 mg daily, immediately. Sequencing of multimodality treatment. Consider patient's performance status, tumor type, and previous treatments.
Treatment planning. Data acquisition. Prefer prone position for direct posterior beam. Supine with undercouch beam is alternative. 3 reference tattoos, isocenter plus bilateral. Target volume definitions. GTV equals vertebral plus soft tissue tumor, MRI-SCT. CTV equals spinal canal plus 1 vertebra above and below, MRI, 2 vertebrae for CT. CTV to PTV margin, 1 cm. Dose solutions. Use 6 MV photons, posterior beam. Typical depths. 5 to 7 cm, cervical or thoracic. 7 to 8 cm, lumbar. Dose fractionation. Palliative, good prognosis. 20 grays of 5 fractions of 1 week. 30 grays of 10 fractions of 2 weeks. 8 grays single fraction.
There are a few MCQs at the end of this video. Watch till the end.
Our next topic is superior vena cava obstruction, SVCO. Causes. More than 90% of SVCO causes are due to malignancy. Most common causes: small cell carcinoma, non-small cell carcinoma, lymphoma, metastases from mesothelioma, any tumor involving mediastinal lymph nodes. SVCO results from compression of the SVC by
tilde tumor near the right main or upper lobe bronchus, bulky mediastinal lymphadenopathy. Obstruction below the azygos vein causes more severe symptoms.
clinical signs: facial neck swelling, distended chest veins, headache. Treatment: SVC stenting is first line if available. Steroids short course used. Chemoradiotherapy if stenting unavailable. RT for non-chemosensitive tumors, for example, NSCLC. Data acquisition: supine planning with 3D CT preferred. If not possible, upright beam using landmarks, CT scans, 3 to 5 mm slices, lower neck to diaphragm. Dose: 20 gray for 5 fractions, 1 week, 30 gray for 10 fractions, 2 weeks. Which of the following is a visible clinical sign of SVCO? Which type of cancer most commonly causes SVCO? Bone pain from metastases.
Indications: persistent pain despite analgesia. Most common from prostate, breast, lung cancers. Data acquisition. Position and immobilization depend on site. Prone for vertebral, supine for most others. Target volume. Must localize origin, hip, rib, vertebra. Include 1 to 2 vertebrae above and below. Post-OP, cover whole prosthesis with margin. Dose: single 8 grays, 20 grays 5 fractions, 30 grays 10 fractions.
What is the most common symptom of bone metastases? Hemorrhage from tumors.
Definition: radiotherapy used to control active, bleeding from tumors hemorrhage. It is a form of palliative treatment, aimed at symptom control, not cure.
Indications: tumor-related bleeding in bladder, hematuria, cervix, uterus, or vagina, gastrointestinal tract, rectal, gastric bleeding, lung or bronchus, hemoptysis, skin or fungating tumors, ulcerated breast masses.
Main goal of radiation is to stop or reduce bleeding. Radiation damages tumor blood vessels, causes fibrosis and thrombosis, leading to vessel closure, shrinks tumor mass, relieving pressure on blood vessels.
Dose for hemostatic radiation is 8 grays single fraction. Gives symptom relief within 2 to 7 days. But we have limitations. It's not always effective for massive or arterial bleeding.
Patient performance status is commonly assessed using 2 standardized scales in oncology and radiotherapy, especially for planning palliative treatments. ECOG performance status, Eastern Cooperative Oncology Group. Grades 0 to 1, generally eligible for aggressive or experimental therapies. Grades 2 to 3, may tolerate modified or palliative treatments. Individualized assessment needed. Grades 4 to 5, supportive care focused. Treatment rarely pursued beyond symptom control.
Karnofsky Performance Status, KPS, scale. Assesses functional capacity in patients with chronic illnesses, for example, cancer, organ failure. Note: KPS correlates with prognosis. Higher scores associate with longer survival. Now try to solve few MCQs related to this topic. A patient presents with back pain and progressive leg weakness. MRI shows spinal cord compression. What is the next immediate step? Which emergency condition is most associated with small cell lung cancer and requires urgent RT? What is the recommended whole brain RT schedule for multiple brain metastases? Have you ever been part of an emergency RT case? Drop your story in the comments. Which imaging modality is preferred for detecting spinal cord compression? The field edge, defined at the simulator, to cover the PTV represents what? Which scoring system is used to evaluate risk of pathological fracture in long bones? For spinal bone metastasis, which beam arrangement is commonly used? What is the approximate overall response rate for pain relief with RT and bone mets? Which type of radiotherapy is typically used in palliative treatment for hemorrhage? Which mechanism contributes to bleeding in advanced cancer? Which of the following is not typically an indication for hemostatic RT? ECOG grade 2 roughly correlates with which KPS range? Which ECOG grade describes a patient confined to bed 50% of waking hours? Which scale uses a 0-5 grading system? Which radiobiological effect is primarily responsible for the quick action of hemostatic RT? A KPS score of 50% indicates the patient. In this video, we have discussed emergencies and palliative cases in radiotherapy. Comment any story you would like to share regarding emergency RT, and also any topic you want to discuss. Please subscribe, share, and like the video.